Hello. We're going to go ahead and do the end of chapter 12. We're going to talk about we're going to start on page 335 of your textbook, and you can see we're going to start with hypervolemia and hypovolemia. Some of the terminology you need to remember: euvolemia is just when the body is just right. We have all of the fluids, everything's perfect. Hypervolemia is when we have too much. You'll also see it stated as fluid overload. It can happen, if you've ever had a real salty meal, you wake up the next morning and boy, it tasted good going down, but you can't get your rings off and on, your feet are puffy, you just feel bloated, your face is all puffy. That's because you're retaining fluid because of the sodium intake. It can also happen when a patient is in a facility being treated and we have given them a lot of IV fluid. We've been pushing that fluid, or we've been pushing a transfusion. You can see that. Medication side effects. But the biggest reason you see it is because of heart failure. And when you think about that, you're going to think congestive heart failure, and they just puff up and they get very edematous, and they're just retaining all kinds of fluid. All right? Hypovolemia is when you have a decreased plasma volume in the blood. Now, don't confuse that with dehydration, because hypovolemia and dehydration are two different things. Dehydration is when your body just doesn't have enough water or fluid. Hypovolemia is when you have a decreased plasma volume in the blood. All right, so don't get the two mixed up. Okay? Volume depletion can happen because of dehydration, because you don't have enough fluids in the body or water, or because of hypovolemia. So volume depletion just means that the volume of what you've got going on is your blood is just not there. Okay? Some other metabolic guidelines for you to remember. When you have a neoplasm, dehydration is going to be your principal diagnosis if the patient is admitted for management of the dehydration because of a malignancy. Okay? Or if it's for therapy for the malignancy and the only thing we're doing is treating the dehydration. In that case, your malignancy will not be principal, your dehydration will. And that really just follows what our main guideline for principal diagnosis, right? The UHDDS guidelines that state the condition determined after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. That's exactly what's going on here. We're not admitting them because of the malignancy. We're admitting them to treat the dehydration. Okay? If you have, then you would code the malignancy as secondary. If you have a severe dehydration that results in acute renal failure, which can happen, you're just not getting enough fluids, your kidneys aren't working, they don't have any reason to, they get lazy and they just stop working. Okay? If that happens, severe dehydration is not going to be your principal diagnosis. Your acute renal failure will be, because the acute renal failure is turning out to be the reason they're there. Okay? It's also the most resource intensive. All right? When you have a patient, sorry about that, I had to take a drink. When you have a patient that's admitted for hypernatremia or hyponatremia, and that is what? That is too much sodium or too little sodium. Okay? When that happens, you don't code dehydration. You only code hyponatremia or hypernatremia. Why would that be? Well, because dehydration is a very common symptom. It's integral to having hyper or hyponatremia. All right? Let's move on to cystic fibrosis. Cystic fibrosis is a genetic inherited condition. It can be inherited. And what happens is that it affects the cells of the body that produce mucus or saliva, or even the digestive juices in the stomach. All right? And what will happen is those secretions get those things are supposed to keep things slippery, right? They're supposed to keep things moving and make things mobile in your body and keep things going smoothly. What happens with cystic fibrosis is that those secretions become very sticky. They become real sticky and gloppy and almost like a glue, and they don't want to move. And if you've ever had a sinus infection where you just have, I'm going to get gross here, but you just have snot plugging up your nose and it's plugging up your throat in the back of your mouth and you can't get it out of there and it doesn't want to move. Imagine that through your whole body and in your lungs all the time. That's what's happened. Those have become real thick and sticky and gross and gloppy. It happens very commonly. That's what cystic fibrosis would feel like all the time, magnified times 10. And then, of course, what happens is you end up with, because you can't move those secretions out of there, what happens? They start to become infected. They just sit there. So it's kind of like if you have a cold and, you know, things are going well, the snot's flowing, and then it just kind of stops, and then the next thing you know, you've got a sinus infection. It's because everything's just stopped up there, and it's not going anywhere, so it's just sitting there to fester, all right? Typically, cystic fibrosis, because there is no cure, we aim the treatment at the complications that show up, or manifestations that show up, like the pneumonia, asthma. Most of it, when you think of cystic fibrosis, you think of the lungs. There may be times when you'll see transplants for those once in a while. That is something that they're starting to do, all right? When you're coding cystic fibrosis, because of pneumonia being a complication for them, it's usually going to be, there's going to be an organism there. However, doesn't mean there's always going to be an organism there. So do not automatically code bacterial pneumonia. Look for the organism to be stated, or look for pneumonia due to an organism. Look for that due to, and that will lead you to, you know, let that catch your eye, and that will lead you to where you need to go for whether or not there's an organism. But don't always jump to that, because that's either going to be abuse or fraud, okay, in some cases. Here's a good one. Organism might be present, and it doesn't mean that the patient has pneumonia due to Pseudomonas. There's a good one. So if you have a patient that has cystic fibrosis and they have pneumonia, and Pseudomonas is there, it's very common in cystic fibrosis patients to have that show up, the Pseudomonas. If it's there, don't just assume that that pneumonia is caused by Pseudomonas. All right? Again, it's got to be documented by the doctor. Remember, we don't get to assume anything. Okay? There are a couple special coding rules. The big one is that a patient that is admitted for a complication of cystic fibrosis, that complication is going to be principal, the cystic fibrosis will be secondary. And that kind of goes against what we have thought about again, and this has happened before with a couple of things, because typically we say you code the underlying cause, right, as principal. In cystic fibrosis, you flip it. You code the complication that you're treating and the cystic fibrosis second, all right? You will see cystic fibrosis with some pulmonary manifestations, obviously. You will also see cystic fibrosis with gastrointestinal manifestations, because again, it does affect those digestive juices, right? And you will have instances where you will have a patient that has both of these. They have the CF with pulmonary and gastrointestinal manifestations. In that instance, you need to code both. So it's a lot like the diabetes coding. So if we have a patient who is diabetic and has peripheral neuropathy, and they also have, let's see, gastroparesis. you'd code both, right? Okay. All right. So try to keep that in mind. Or if they, a better example would be peripheral neuropathy and ophthalmic manifestations. You'd code both. So you'd have diabetes and with neurological manifestation, and diabetes with a ophthalmologic with an eye manifestation. There you go. That's right. It's been a long day, folks. Okay, so this is the same thing. Cystic fibrosis with pulmonary, cystic fibrosis with gastrointestinal, and then what do? You have to say what those conditions or manifestations are. All right? Dysmetabolic syndrome X is a type of obesity where we see insulin resistance, dyslipidemia, which means they could have hyper or hypolipidemia, right? They have hypertension. They have abdominal obesity. So these are people that carry almost all of their weight in their stomach. Don't get it confused when you see dysmetabolic X or you see abdominal obesity. That could be Cushing's too, right? Cushing's has that. So if you see that the physician writes abdominal obesity, don't automatically think dysmetabolic syndrome X, or don't automatically think Cushing's. These people are greater risk for a couple of things, obviously, because of the insulin resistance, type 2 diabetes, cardiovascular disease, and we've heard that, right, out in the media. If you carry all of your weight in your stomach, that's a bad thing for your heart, strokes, etc. You may see this documented as just plain syndrome X. All right. If you look at ICD-9, there is an instructional note that you need to pay attention to, that you do need to, if you have syndrome X with any manifestations, you need to code those additional manifestations. So again, what do you need to do when you're coding? Read, right? Okay. Obesity, we all know what that is. It's when we have an increase in body weight. Body mass index is what we're using now. We do have to report on that. You will use V codes when you're coding obesity, because that will give you the patient's body weight, body mass index, BMI. So you need to make sure that if you have obesity, if you have it, you go in and code the BMI. Now, BMI, you can go in much like ulcers. As long as it says obesity, you can go by the doctor. You can go to nursing documentation or someplace else to get the BMI if they've recorded it. Okay. Be aware when you are in the section for coding BMIs, the V code section, there is a section of there's a category of V codes for adults and one for pediatric. So don't get those confused, because it's two entirely different codes. All right? Different set altogether. The definition for morbid obesity is that patients are 50% to 100% or 100 pounds heavier than their ideal body weight, or they have a BMI of 40 or greater. There are complications, right? Diabetes, hypertension, heart disease, stroke. There's a whole list of them, right? Okay, so kind of watch for that, but know that this is the actual definition right here for morbid obesity. So make sure, if a doctor documents that you've got the information documented to back that up, right? Hypervitaminosis. Did you know you could overdose on vitamins? Absolutely you can. Absolutely you can overdose. The big ones, though, that you really can overdose on are the fat-soluble ones, which are the D, E, A, and K. So if you remember DEAK, D-E-A-K, fat-soluble vitamins right there. When you have an overdose like that, it's a toxicity, you might be coding a poisoning. So check and see there. And where do we run into that? Well, little kids, those gummy vitamins, they're making vitamins taste more and more like candy every day. A little kid gets into them, eats them all. Maybe somebody who thinks more is better, If one is good, 2 is better, right? And 3 or 4 is best. They could be, getting themselves into trouble with that, with hypervitaminosis. So keep an eye out. I've never actually seen a case of it, but it doesn't mean it doesn't happen. It happens all the time. Tumor lysis syndrome. Tumor lysis syndrome is when you have treatment for cancer, usually leukemias or lymphomas, and it's when the cells, the dying cancer cells, break down, all right, and they destroy the electrolyte and metabolic systems. They just cause all kinds of disturbances, and you might see hyperkalemia, you might see hypocalcemia, you might see all of these different things that are listed, and those are all part of tumor lysis syndrome. Acute renal failure can happen as a result of it because your body's trying to get rid of all of that waste, and now you've got a huge amount of it, right? That can happen. There may not be a lot of symptoms right at the beginning when you're talking tumor lysis syndrome. What they do is they direct the treatment at whatever the manifestation is. So if it's hyperkalemia, they'll give them medication to help with processing all of that. Hypocalcemia, they'll give them calcium. Sometimes, typically what they'll do is prior to the treatments, they'll give them some type of a preventive medication like bicarbonate, sodium bicarb, and if you remember, we did have a case study that we did where they talked about where they did alkalinization of the urine with sodium bicarbonate. This was why. They didn't want the patient to develop tumor lysis syndrome. It can be deadly. It can cause arrhythmias, seizures, all kinds of problems, and if it's not treated, a patient will die. All right? Immunity disorders. The immune system. Big one, right? That's our major defense mechanism. That's when we're being invaded by foreign substances like bacteria and viruses. The body kicks in to, they send out the little armies, right? Well, there are different types of responses that can happen with your body. Hyperactive responses, those are allergies. Those are allergies, right? We have immunodeficiencies. We have autoimmune disorders. All right, we have situations where we have attack on beneficial foreign tissues. Well, what does that mean? What is a beneficial foreign tissue? Well, if we are giving you blood transfusions that are not coming from you, they're not autologous, then that is a beneficial foreign tissue, right? And your body can attack that. Same thing with any grafting, skin. Same thing with any transplants. All right. So, people that are at risk for this are people that are immunocompromised because of certain medications that they take. If they're immunocompromised because of chemo or radiation, or if they're receiving immunosuppressant drugs for transplants. If you expect this to happen, if you expect them to be immunocompromised because of these, and you're giving them medications to make them immunocompromised, you do not code that expected result because you're doing it on purpose, okay? You will code for unspecified disorders of immune mechanism, but it should only be assigned if the underlying cause isn't known. Typically, when we're dealing with immune mechanism disorders, we'll know what it is, hopefully. All right. Graft versus host disease. This is very common when we have a stem cell or bone marrow transplant, and basically It's when new transplanted material attacks the patient's body. So whoever is getting the transplant, they'll get the new stem cells or they'll get the new bone marrow, and all of a sudden it starts to attack their body. And there are actually two types. There's acute GVHD and there's chronic GVHD. Acute happens within the first 3 months from the time of transplant. Chronic starts after the 3rd month. All right, so somebody could be in the acute phase and then cross over into the chronic phase, and that's when they're diagnosed as chronic. When you have both acute and chronic, in both of those, the patient is going to be really susceptible to infections because they're just being attacked already. The body's just under constant attack. You will see that they have in acute, they have diarrhea, vomiting, weight loss. They get a rash, a skin rash, jaundice because their liver is just being destroyed in the spleen, right? When you see chronic, you will see that they have hair loss, they have hepatitis, they have very dry mouth and eyes, mucous membranes, which is another, that's very common in immunodeficiency or in autoimmune disorders, such as Sjogren's disease, things like that. You will see that they've got dry mouth, dry mucous membranes, dry eyes, all right? There will be lung and digestive tract disorders. Their skin will get thick. Their skin will thicken up. All right. The other way to really treat this graft versus host disease is steroids, immunosuppressants, immunoglobulins, antibiotics. They try to keep the body from attacking itself, or keep those new cells from attacking the body itself. Okay. Watch for personal history codes. Watch for your BMI for your adult and children. When you're talking about endocrine and metabolic disorders, because a lot of them are inherited, or you'll see family histories. You'll see that we do special screenings for a lot of those things. Dietary surveillance and counseling, that's going to be for the diabetes, right? Big one. And then your BMIs for your adults, and you've got that second set for children, so don't get them confused with those V codes. Then we have our treatments. So our big one is we do a lot of surgical treatment, right? For goiters, for the hypothyroidism, for the hyperpituitarism, the Cushing's, we'll do surgery. We'll also do radioactive iodine. The radioactive iodine is one that we do. And we'll use that for treating, again, goiter. And the hyperthyroidism, right? Because that's what causes a goiter, it's the deficiency of the iodine. We treat a lot with vitamins, nutrients, protein, that kind of thing. We do radiation for hyperpituitarism. You'll see that. We do the radiation to try to shrink that down. Diet and exercise, obviously. A lot of this is just behavior modification, right? You will see that we do exploratory work. There is a lot of diagnostic surgeries, excisional surgeries, because a lot of these issues are caused by what? They're caused by a growth on a gland. So we go in and take them off, okay? We don't need to worry about the ICD-10 yet. Bariatric procedures, those are some big ones that are coming up. Malabsorptive, we have two types of obesity-related surgeries. We have malabsorptive and we have restrictive. Roux-en-Y or gastric bypass is the big one that everybody hears about all the time. And that's where they actually bypass part of the small intestine so that your body doesn't have the ability to absorb. It doesn't have the chance to absorb all of the fat and the bad stuff. All right. There's also two others that fall into that category: biliopancreatic diversion and duodenal switch procedures. They're quite involved. Those two are quite dangerous. Roux-en-Y is becoming very common. If I were you, I would Google that and watch one of those surgeries, particularly the Roux-en-Y, so that you understand what it is. Because then we have the restrictive, which is the gastric banding or the vertical banded gastroplasty, but there's also another one called a vertical sleeve gastrectomy, or VSG. That one is becoming the most popular right now. You need to look at that one. If you're going to look at any of these, I would recommend you go out and watch a YouTube video of a Roux-en-Y gastric bypass, one of a gastric banding procedure, and one of a vertical sleeve gastrectomy, to understand how those procedures work and what they do. And there's a lot of information out there, all right? So I would go out, I would watch that. Because the restrictive then is going to just restrict how much food you can actually eat in a sitting, okay? Insulin pumps, they look like a beeper. And it's a pump that the person that's wearing it has to, they have to control it. They have to, when they sit down, they have to guesstimate how many carbohydrates they're eating, and they put that in, and then the pump will deliver the correct amount of insulin for them. And it's a little needle that goes into under their skin, and it stays there for so many days, and then they pull it out, and then they put the new one in, and it just gives them a continuous drip of insulin to help stabilize and keep everything normalized. If need be, the patient does have the ability to give themselves a bolus or a boost of insulin. All right, so the thing about these is you have to be very compliant. And you can actually go out and, again, YouTube insulin pump. Look on YouTube for an insulin pump video, and you'll learn a great deal about them. Particularly if you don't know a lot about diabetes, go out there and take a look at it. All right. The big thing you're going to have is you're going to be waiting for pathology results a lot of times on these. And sometimes pathology can take a while, all right? Because most of these endocrine and nutritional and metabolic disorders, the documentation that supports them are laboratory tests and pathology tests. So you're going to have to wait for those before you do anything. Also, you may have to query your physicians quite a bit to find out on some of these more unusual things. All right. If you find that you're querying a physician a lot, then what do you need to do? Give him some upfront education. All right. Watch for acidosis and alkalosis, hyponatremia, hypernatremia, malnutrition. Those are the most common things that we miss, and these are all CCs. These are all going to affect your reimbursement. Remember, we talked about CCs and MCCs. These are all going to affect your reimbursement, so watch for them, okay? You are going to have, make sure that you understand your dehydration, particularly your dehydration versus your hypovolemia. Make sure that you don't code your hypernatremia or your hyponatremia with your dehydration. Remember, we talked about that. If you have two or more conditions that are present on admission and they both meet the definition for principal diagnosis, you can use either one. Okay. Urinary tract infection. You may have urinary tract infections with some dehydration. Okay, watch for the dehydration being treated aggressively with IV fluids, and watch for a UTI being treated with IV antibiotics. If they are both treated during an inpatient admission, then you code either one as the principal. It doesn't matter which one you code, but if you're going to code that dehydration, you have to see somewhere that it was treated very aggressively with IV fluids, that they were really pumping that person full of fluids, okay? Let's say you have a person that comes in and they have a UTI with dehydration, and we give fluids for the dehydration but oral antibiotics for the UTI. Before, we gave them IV antibiotics, if you look above. but we're now giving them oral antibiotics. When that happens, you have to code the dehydration as the principal diagnosis, not the UTI. They are not on an equal level at that point, okay? Malnutrition. How do you know if you have malnutrition? Well, one of the clues is that you will see some nutritional consults, or a dietitian will have some notes in there. All right. If a dietitian or a nutritionist did see a patient, that is not the same as getting a consult from another physician. You have to confirm that diagnosis to make sure. So they may write a diagnosis in there, but you need to go back to your physician and confirm it, right? Okay, query them. Diabetes is going to be can be a little bit difficult, because you're going to see a physician might write type 1 in one spot, and they might write type 2 in another, and then they go back to type 1, and they might write non-DDM here, or NIDDM here, but then they write IDDM here. So you need to make sure that you watch very carefully and query the physician. Okay. Always make sure you have your codes, your diabetes code sequence before your manifestation codes, and always make sure you have, if you have a manifestation, you're going to have 2 codes for each. You're going to have 2 codes. You're going to have the diabetes code with the what type of manifestation, and then you're going to have the actual nature of the manifestation. All right, so don't forget that. You can end up with quite a few codes. All right, so good luck. I will see you on Monday. Have a good weekend.